Welcome back. Here in the second half of our program, I'm welcoming Leanne Smiley. Leanne is the clinical manager with Home Health. Good morning.
Good morning.
Welcome.
How are you?
Leanne is here to talk to us about home health. Leanne, tell us how you got into your job. What's your background?
My background is I'm a registered nurse. I trained originally in a large trauma hospital in Australia. So for the first 15 years of my career, I worked under a very different system of healthcare. It gave me a great background in a lot of things, but I admit I transitioned very quickly to community health, and I was working as a community health up until the time that we moved here, and we've been in the United States almost 18 years at this point. Did some work in rehabilitation and truly believe in the ability to get people back to their prior level of function, if not a little bit better. I then moved into home health because home health was a natural progression to bring those rehabilitation skills into the home, because I truly love working outside of a facility. The home for me is where we can truly treat the individual and get to know the individual, because we all know that when you go to the hospital, you're in and out very quickly and you truly don't get to know the people that are looking after you. Sometimes when you're in a long-term facility, you get to know people, but generally those stays are relatively short. Whereas in the home, we have the ability to get to know someone in their home environment and how they interact with that environment.
And the patient feels much more comfortable in his or her own home also.
It does, and everything we read and all the research suggests that care provided in the home is the preferred setting. You know, whether it's a type of acute care, whether it's outpatient, however we do care, you know, people don't want to go to the hospital and spend nights in an environment where you don't sleep and you're not comfortable because of the bed and constant interruptions. And there's definitely times where that needs to happen, but people want to be home as soon as they can. And even for someone who spends some time in a facility such as Garden Ridge, there's always that desire to come on home and be somewhere where, you know, you can close that door and have your privacy and have your things around you.
You're familiar. Have your stuff around
your stuff,
you.
Yeah,
that's the most desirable.
It
also.
is.
Right.
And you know, for my clinicians, I have nursing and therapists. They've practiced in the home for many years, and each one of them truly recognises the benefit to having someone with their stuff and in their familiar surroundings, because it does present an opportunity to get someone to where they need to be happy and, you know, doing what they want to in their environment, and in here, you know, being interactive with our community.
Well, it just occurred to me, is it more likely if a person has physical therapy in his or her own home that the person will continue to practice those exercises or whatever than if the person had the therapy outside the home?
You know, that's true for some people, but not necessarily the case. Quite often, our transition plan, when someone is no longer qualifying for certified home health, and Medicare is very strict in the criteria. You know, you have to be homebound. You can't be doing, you know, a lot of things other than, you know, basic function, things like getting a meal or whatever. So at that point, when someone does get functionally able to get out in the community and be a participant, which is what we're striving for, we have to transition to outpatient therapy if it's still warranted. Some of our clients choose not to continue with therapy and just continue with the home exercise programs that were developed during our time with them. Others take those home exercise programs and expand on them through the use of our outpatient therapy departments.
Okay, I'm sorry, I got myself off topic there, and I shouldn't have. Let's back up 1 second, because I want to start at a point when you and I talked before we came on camera here. Some confusion on my part. What is the difference here at Green Spring between home health and home support?
Yeah. There is an awful lot of confusion because home is in both of those words.
Right.
And the difference truly is for certified home health, which is my team, Medicare is the primary payer. So Medicare covers the cost if someone qualifies as medically necessity by their doctor. We have physical therapists, we have occupational therapists, we have speech therapists, we have nurses. Home support is a private pay system. once someone is no longer progressing or needs long-term help, then Medicare won't cover what it calls custodial care.
So the home support people are the ladies and gentlemen in the green tops?
They are.
Okay.
And the green tops are for the aides. You'll also see some ladies and gentlemen in blue tops, and they are companions, so they work for home support. Home support also has its own nurses, and those nurses in home support are working more with the long-term issues, because certified home health truly is set up as an extension of the acute care system until someone is at a point where they can be independent or independent with assistance. So the nurses in home support do things like med box fills, filling the pill boxes for someone who needs that type of support within their home. Their aides will do medication reminders. The nurses will do some follow-up of long-term things like if someone's got a feeding tube, they can do some of those things. We can't continue to do those because, again, what Medicare is saying is that's a long-term need, that's not a change.
So all of those are home support, and all of those are paid by the resident.
They are.
They are never paid by either insurance or by Medicare.
The only exception to that is if someone has a long-term care policy. Sometimes under the terms of their policy, and every policy is different, under the terms of those policies, sometimes they will pay for some of that private care as an alternative to going to somewhere like assisted living or whatever.
So the key there being sometimes under the terms of that policy.
Exactly, and every
Right.
single one of those is different. So we have a team of expert people down in home support who can take a look at those policies and work with the insurance companies
And that's
when
good
they
to
need
know.
to. Yeah,
That's good to know.
it is.
So if someone needs home support, important to know that there's someone who could look at that policy
And see where
right,
we're at.
because sometimes calling an insurance company,
You need
kinda
some
get a
help.
runaround. Right, okay.
You do, and with our team, we are primarily paid by Medicare, but also by private insurers if someone has an Advantage program. So we work with Ericsson Advantage, we work with Aetna and Blue Cross Blue Shield. The resident never sees those bills. We bill directly to either Medicare or to those entities, as long as we can justify that the care was provided. So there is no out-of-pocket cost for the resident for our services.
Okay, let's talk about when your team comes in.
So generally our team comes in, we get our referrals from a variety of sources. We get them from our acute care hospitals. We have a liaison, Brenda Jenkins, who works with us and is an employee of Green Spring. So she's out in our hospitals in Nova and Fairfax looking after our residents and seeing where they're at and what their needs will be. Brenda sends us a significant number of referrals because the patient or the resident is needing that care when they come home. She also will refer to Garden Ridge when needed. So she's actually working for all the groups here that may be part of a resident's aftercare from a hospital visit. We also get our referrals from Garden Ridge. So a person may go to an acute care setting and then transition to Garden Ridge, stay a while in Garden Ridge, and then it's deemed that it's a great time to go home and be independent at home. We get our referrals from there. The other place we get our referrals is directly from our physicians, someone's primary care doctor. So it doesn't require that you spend time in the hospital. It doesn't require time.
So Brenda is an advocate for our residents.
She is.
And as long as our residents are keeping in touch with, as long as she knows that our residents are having a medical issue.
She is the lady that will visit within the hospital. So she's actually located in the hospitals.
Okay.
So if someone went to an Nova Fairfax, for instance, Brenda collects the hospital list for our residents every morning, knows where everyone's at, and then we'll follow up with either the resident or their family, depending on the medical issues that are going on.
Good.
To start to look at what that discharge plan might be, because for all our healthcare services, we have to look at discharge from the time that we admit someone. You know, what's going to happen to someone when they leave our care. So Brenda's role within our hospital system is truly to be there for our Green Spring residents, identify what their needs will be, and then either make the referral to Garden Ridge or to Certified Home Health or Home Support or Hospice, which you just spoke about. So Brenda is very knowledgeable about all our care and can help the resident to make the decision about what the best level of care might be for them.
And in addition, our medical center here could identify someone as needing home health without having gone through a hospital.
Absolutely. Either our medical centre here or some residents have physicians outside of the community. We can work with those physicians to get the referral information that we need to identify the medical necessity. Again, the resident has to be homebound. That is Medicare criteria, but quite often someone becomes isolated within their home because they can't get out and about. And you know, the only place they may be going is to their doctor's office visit, you know, with the help of a family or a friend. So they're where we should be getting a lot of our referrals from, because not everyone goes to the hospital every time they get sick.
So the services that can be provided within the home are physical therapy, and what else?
We also provide occupational therapy. We provide speech therapy. We have 2 wonderful speech therapists that work with us, and they're working not just on swallow and eating issues, they also work on cognition. So along with our occupational therapists, they truly focus on if someone maybe is a little forgetful, developing some compensatory mechanisms to help them stay in their home and be safe. We also have a home health aide that works with our therapists. If the therapist determines that it would be beneficial for our aide to go in and continue that training either in a shower or personal grooming situation, we can provide services for the duration of our care based on what the occupational therapist or physical therapist is asking to do. We also have a wonderful team of nurses who work with us and for us, and many people in the community know Stella Beeson. Stella is a mainstay of our nursing team, and we also have some PRN nurses that work with her. She is able to go out, she assesses wounds, she monitors conditions after people come home. For instance, if someone comes home with congestive heart failure, she's able to go in and monitor blood pressure, edema, all the things that might happen as a result of that disease. She works with oxygen, making sure that people with pulmonary type issues. So she has a very wide range, and with the other nurses that we have on board, we're able to provide that ongoing service through nursing as well. How else do we have? That's effectively our team.
If a person knows that he or she is going to have an upcoming, for instance, I have a friend who's about to have a hip replacement.
Yes.
Should that person contact your office in advance?
They can definitely contact our office in advance and have a conversation. Quite often what happens when someone is having a procedure planned, like a hip replacement, the surgeons have their own system of working through what we need. We work with some surgeons and we're able to provide the care, but quite often the surgeon has a desire to get people moving a lot quicker than spending time within Certified Home Health. So they'll use us if someone's not progressing as quickly as what they would expect, but quite often that person's going to go straight to outpatient therapy to use the equipment and things that are available within that setting.
Okay.
But you know, definitely have a conversation with us, especially if it's maybe not an orthopaedic procedure, because we can definitely be ready when someone comes home. And we've had residents who have called us and said, you know, I'm having a surgery for a cancer or I'm having something removed. How do I make sure that I have the help when I get home? And we've been able to be in touch with the social workers at the hospitals, especially in hospitals that Brenda doesn't go to. So the MedStars and Virginia Hospital Centre, we're able to work directly with those social workers to make sure that when the resident does come home, that we have the orders, we know what the doctor wants, and we can make plans for, you know, where they go when they discharge from us.
So this really is a team effort.
Very much a team effort.
I have one other question. Is there ever a time when your team works in combination with home support?
All the time.
All the time.
All
So
the
there are
time.
times when both your staff and their staff
Will be in.
are on site.
And why that's the case is quite often what our therapists or our nurses will identify under certified home health is that resident's going to need care for long after Medicare will provide payment for services. So the resident may need ongoing medication management, which the nurses from home support can help with. That resident may need ongoing help with bathing because they're not safe in the shower, and the shower is one of the most unsafe places that anyone can be, in which case they may hire an aide through home support. So again, you know, we're working towards making that transition as smooth as possible, but there will be times when both services are in.
Right. Interesting.
Yeah.
Thank you so much for your information. And I think like many of our other services, it's important for us to know what's available, know what it is, and know to reach out when a time comes that we do need such services, that there's a possibility that we may. Anything else you'd like to add?
I just want to say, you know, we really appreciate the opportunities to come up and spend time on Channel 6 and in other forums within the community to share what we do, because again, unless something's happening to you, you may not be aware of what the information is, and quite often in a time of crisis, you're looking for that information, and we can definitely make sure that that information is available ahead of time.
That's
for
right.
when those things happen.
At
So
least
thank
we'll
you.
have it in the back of our heads that it's there.
Exactly.
Thank you so much for coming.
All right. Thank
All right.
you.
And we have a few announcements here before we leave you today.